Hey everybody, welcome back to Palm Peeps. I'm excited today to be back with Luke Hedrick and doing another rapid fire journal club. We had a lot of fun discussing ARDS trials, a bunch of landmark trials in ILD, I think was the last one we talked about. And we have another great article to discuss today. Luke, how are you doing?
Hey, Dave, I'm good. I'm happy to be back. It's been a minute, but I think this will be a nice addition to the Journal Club series.
Yeah, and without further ado, we don't have to build up the suspense too much more. What trial are we going to talk about today?
Yeah, so today we're going to be talking about the MIST-2 trial, which was published in the New England Journal in 2011.
Great. Yeah, I think that this is a real, truly practice-defining trial. We've talked about a lot that really shape our practice, and we'll dive into the details of what, but I think that this is one where very specifically the protocol in the trial has become a real standard of care. Let's talk about what's going on. So we know that there's going to be some background since this is MIST-2 and there was a MIST-1 trial. So why don't you tell us what the background was leading up into this trial?
Yeah, so we know that infections in the pleural space are common and morbid and often require surgical intervention to definitively manage. And unfortunately, antibiotics and chest tube drainage alone often fail. The MIST-1 trial, which was published in the New England Journal in 2005, studied intrapleural streptokinase, and unfortunately that showed no benefit. And so here, the MIST-2 trial was a study of intrapleural TPA and DNase to try to ease drainage of these infected effusions by breaking down septations and thinning the pleural fluid itself.
Yeah, that's great. We've talked about complex pleural effusions previously on the show. We've talked about infected pleural spaces and empyema previously. This is a common problem that every pulmonologist is going to run into that you might see in the ICU, but you also might see in the clinic and the floor. And it's a really interesting one because it can affect people of all ages. I've definitely seen immunosuppressed people with really badly infected pleural spaces, but I've also seen the young, really totally healthy person who had pneumonia, maybe got therapy or maybe honestly muscled through and then developed a severe pleural infection. And so having guidance of how to manage it is super helpful. And we're really thinking about enzymatic therapy. I call this enzymatic therapy as its combination. Intrapleural TPA, less of a pure enzyme than DNase. The combination of them of trying to break down septations, thin the pleural fluid collection and drain it appropriately is what can help make these people better. So what was the study? They wanted to answer this question a little bit more thoroughly and with a different protocol than in the first trial. So what study design did they come up with?
Yeah, so this study here was a double-blind, double-dummy, 2x2 factorial RCT that was run at 11 different hospitals in the UK from December 2005 to November 2008. And by double dummy, what I mean is that there was actually a sham placebo for each of the study drugs, which is pretty interesting.
Yeah, it is really interesting. It really helps add to the validity of the study that you're giving a placebo intervention. And these are very physical to give a placebo because you're thinking about going and instilling something into the chest tube. So really nice that we know everybody's really blind to this, the patient, the treaters, the investigators. One thing that's really important with these infected pleural space infections is the outcome that we're looking for, because we're talking about a different set of outcomes than we may be in our classic ICU trials or our classic chronic pulmonary disease trials. So what were the primary and secondary outcomes that they wanted to have some insights into?
Yeah, the primary outcome here is a little bit wordy, but it's the change in the percent of the hemithorax that's taken up by the effusion on chest x-ray at day 7 compared to day 1, which is like a roundabout way of saying how much do we think we got out. We're not looking at just milliliters of fluid, but relative to that patient's own imaging. And then the key secondary outcomes that they looked at were referral to surgery, hospital length of stay, all-cause 3-month and 12-month mortality, and then safety, any kind of adverse effects from instilling TPA and DNase into the pleural space.
Totally. And I like this combination of outcomes because the primary outcome really gives us that functional, how did we do with this therapy? Did it have the intended physiologic effect that is represented by a radiographic finding that we were shooting for by giving this therapy. And then all of the secondary outcomes are the key ones that we care about for these patients. And I'll make a special note about the referral for surgery. This is often the endpoint of interest in these pleural interventions for infected pleural spaces, because we know that there is a surgical option that can be done. You can always go in and open and clear out the pleural space, but you often want to see if you can get away without doing that to decrease morbidity for the patients. All right, so we know what we're going to be thinking about. Now we should think about who these patients are. So what were the key inclusion criteria that we had for this study?
Yeah, so the inclusion and exclusion criteria, I think we're aiming to cast a pretty broad net. So in terms of inclusion criteria, anyone with clinical evidence of infection that was assessed by the recruiting physician, so fever, CRP, white blood cell count, and then also had pleural fluid with any of grossly purulent drainage, a positive fluid culture or gram stain, or a pH of less than 7.2. Any of those would get you included in the trial. And then in terms of exclusion, they were aiming to exclude people with increased bleeding risk because of the TPA that was being instilled, or people who they didn't think could re-expand the lung after drainage, because that's really what drives the benefit other than source control. A lot of the benefit people get from drainage of effusions is from re-expanding the lung. And so if you can't do that, you're unlikely to really benefit from the trial in the first place. And so those exclusion criteria were an age under 18, if you had previously gotten intrapleural medications, so fibrinolytics, DNase, or both for an empyema, if you were allergic to any of the study drugs, if you had a coincidental stroke, and so really they're thinking about the hemorrhage risk, if you'd had major hemorrhage or trauma or major surgery in the last 5 days, if you'd had a previous pneumonectomy on the infected side, if you were pregnant or lactating, and then the kind of usual catch-all of expected survival less than 3 months from something other than what caused the pleural problem in the first place.
Yeah, that's great. I think casting a broad net, really capturing the people we want to think about. A few interesting notes on this. I think that their inclusion about the pleural fluid studies, it really shows us that in practice, there's sometimes less of a clinical distinction between complex parapneumonic effusion and empyema. The classic empyema is that grossly purulent fluid that comes out of your pleural drainage. But then we also think about getting there with a really low pH or positive cultures, or having a complex parapneumonic effusion that meets one of those criteria. And this is including all of those people, because any of those people are those that might need to progress to surgery or might have really morbid outcomes if we don't end up fixing this pleural space. And then I'll just comment on the exclusion. There's a lot of debate about how much bleeding risk there is by instilling TPA into the pleural space. Obviously, some of this will have systemic effects. That being said, you're not giving IV TPA, but I think it's very reasonable within a child to be conservative and say that anybody who has an increased risk of bleeding, we're going to exclude, just so we have a true sense of how this intervention can help people in the purest sense. And so, Luke, I always love that you summarize who these people are for us and we give a good blanket statement. So who, after we've done this inclusion exclusion, who are we really looking at?
Yeah, so who they ended up including were middle-aged, mostly male patients with complicated pleural effusions or empyemas that occupied about 1/3 to 2/5 of the hemithorax, with mostly small bore chest tubes for mostly community-acquired infections. And small bore here, they meant less than 15 French in size.
That's great. And I think this goes into some of the previous existing data on pleural interventions and chest tube drainage. We've had prior trials that show that small bore chest tubes for complex parapneumonic effusion or empyemas are generally just as effective as surgical chest tubes, even though they have a smaller French caliber. Whereas opposed to, say, maybe like a hemothorax, we're usually leaning a little bit more towards a larger bore chest tube. So that brings us to the intervention a little bit. You already mentioned it's small bore chest tubes, but I think the particulars of how they were actually doing this intervention is really important for how we could bring this trial into practice. So what were the specifics of the intervention?
Yeah, so this was a 2x2 factorial trial. They took 210 patients and then randomized them about one to one of the following four arms. So either TPA and DNase, which were 10 milligrams and 5 milligrams, TPA and placebo, DNase and placebo, or double placebo. And then those medications were both given twice a day for 3 days with clamping of the chest tube for an hour after each dose in an attempt to keep the drug in the pleural space and let it act for a little bit. And those drugs were not necessarily given at the exact same time. And so a lot of time at the bedside instilling medications and clamping tubes, and then returning an hour later to unclamp tubes.
Yeah. And if you, I don't know if you've done this in fellowship, I definitely remember doing it, going by, putting the drug in, coming back, opening up, putting another drug in or putting them in the combo. And I think this guidance is really helpful for what we do in practice, especially because we have these arms that compare it to what if you just used one drug. And we actually have a whole other trial of just what streptokinase did. As you mentioned, the missed one that didn't have this effect. The devil is in the details. And we really like to focus on trying to do it exactly as they did in their combined intervention arm. So with that, what did they end up finding? What were the outcomes that they ended up seeing in the trial?
Yeah, I think in general, it's worth just discussing the outcomes of that TPA and DNase arm in combination, because there was a highly significant interaction between the two for the primary outcome with a P of 0.002. And so first thinking about efficacy, that primary outcome of pleural effusion size reduction was significant. They found a almost 30% reduction in the space in the hemothorax that was taken up at baseline versus a 7.9% reduction of effusion size with the placebo. And interestingly, neither drug worked on their own in terms of just draining the fluid out.
Yeah, that's exactly really helpful to hear about how the arms that we had of the single drugs really didn't give us that same reduction. And so if there ever was a time, I remember one time I had a patient where there was going to be a delay on the TPA and they said, could we just do the DNase? And obviously logistical things come into play, but this really showed that it's this combination, this synergistic effect that we're trying to capture. So that's great. We know we achieved this radiologic outcome that probably represents some physiologic significance, but what about clinically meaningful outcomes for these patients?
Yeah, and so that kind of leads us to those key secondary outcomes. The big one, I don't want to bury the lead too much here, was referral for surgery. So in the TPA and DNase arm, only 4% of patients were referred for surgery versus 16% in the placebo arm. So an odds ratio of 0.17 and a p-value of 0.03. The other secondary outcomes were generally neutral to favorable. So the hospital length of stay, when you excluded a nearly 400-day outlier in the placebo group, favored the TPA and DNase. The mean length of stay was just under 12 days versus 17 days. And then there was no mortality difference. And overall seems like it drained the fluid. People got out of the hospital quicker, and a good chunk of them did not need surgery compared to the placebo group.
Yeah. I think as you said, that's a lead. You're getting to avoid surgery for a healthy chunk of people. 16% is not a huge number, but going down from 16 to 4% has definitely a big impact. And I don't think it's so surprising we didn't see a mortality difference. We certainly have multiple treatments for these infected pleural spaces. These patients were closely monitored. So even the ones where it wasn't working, I'm sure are getting very good care. And so it makes sense that you might not see that mortality, but hospital length of stay, referral for surgery are certainly very clinically significant. And then you mentioned some of the concerns with the exclusion criteria about safety. We are doing an active drug therapy into this pleural space. So we always have to think about adverse events for these patients. Was there any difference or signal in the adverse events between the groups?
I think just to be succinct with it, there really was no difference in adverse effects between the groups. There were 6 serious events across all 4 arms that were mostly related to bleeding. There was some intrapleural bleeding, some GI bleeding, and some hemoptysis. And then the other adverse effects were made up of some combination of discomfort or pain with drug administration. So the actual flushing into the pleural space. A couple folks had some transient mental status changes and then a rash. But overall, there was no difference between the groups. And so it seemed like it was pretty well tolerated, all taken.
Yeah, that's great. Certainly the pleural space is very sensitive. There can always be pain with this, but we always have to balance the fact that there would be pain if you had to have a surgical intervention as well. And even the chest tube alone could certainly be painful for some people. All right, so we've talked about the outcomes. We talked about who were the patients. It seems like we have a really positive effect in intervention. What's our gross takeaway? What are we using this trial to guide our practice about?
Yeah, I think the newspaper headline version of this is that combination intrapleural enzyme therapy with TPA and DNase improves drainage of infected pleural fluid and reduces the need for surgery and hospital length of stay.
Yeah, fantastic. I think a truly practice-defining trial. We're doing this maybe not every day, but every week or month in the hospital for patients who have this. And based on this trial, we should really be looking for reasons to give patients combination enzymatic therapy as opposed for reasons for them not to get it, because we think this is a positive intervention that will have good outcomes for their future lung health, their lung expansion, and for not needing surgery to get there. All right. Thanks, everybody, for listening. Thank you, Luke, for, again, an excellent study and walking us through so efficiently and succinctly. And we'll see you all next time when you tune in for Palm Peeps.